Well, welcome. Tonight we're going to explore an area that we haven't talked about before, and it's cosmetic surgery and what goes into it. I mean, we all see everything on TV, but like everything in Milford, there's a practical side and something we can be proud of. So let's start with an introduction.
Sure. Thank you all very much for having me. My name is Dr. Eric Carniel. I'm one of the facial plastic surgeons at Milford Regional Physician Group and Milford Regional Medical Center.
Now, facial plastic surgeon, what that?
That's a great question because it's something that most people actually don't know about. And so within plastic surgery itself, we have the general plastic surgeons, and those have gone through their general plastic surgery residencies, and they've learned about various breast diseases, all the other wound care, and many other diseases all over the body, including especially a lot of reconstructive surgery. In my training, I actually focused first in head and neck surgery specifically. And so for 5 years, I underwent just training that involved from the shoulders and up. I did some operations from further down, but most of my training was absolutely from involving the neck, the face, and the internal organs of that area. And then after that, I went and did additional training just in facial plastic surgery. So I did additional training in very specifically just aesthetic procedures or cosmetic procedures that involve our face, our neck, our face, our eyelids, our noses, our lips.
If you didn't look so young, I would say by the time you're done with your training, you're ready to retire.
Well, that's it. Well, it's because I got some good sleep last night.
My God, how many years? So you go through 4 years of college, there's $250,000. Then you go through 3 years of med school?
4 years.
So there's $300,000. Then what?
Then 5 years of head and neck surgery training. Then
hopefully they pay you some miserable stipend to keep you alive.
And then 1 year of facial plastic surgery.
My God.
And actually, I was part of the 7-year medical program at Boston University. So I was going to get out just in 3 years of undergrad and 4 years of medical school, and then I decided to tack on an additional program during it. So I then was not only a BA and MD, but I also went to the MD MBA program as well. So I still stuck it out to be 8 years at BU, but I was able to get 3 degrees then.
Okay. And your parents are saying, Eric, are you ever going to make a living? Are you ever going to make any money at this?
Well, the good news, at some point, I'll finish, and now I'm all done. So I always joked with people, when I'm telling young people about going into medicine, I did as many years of school before graduating high school, meaning grade 12, as after. Oh. And I actually did more years after.
Well, we've had these discussions with a lot of the kids. I went to Holy Cross, and a lot of them look at a career in medicine, and I keep telling them, if you have a passion for medicine, then like any passion you have, go for it. Mm-hmm. But if you're doing it for the old reason of it's a steady income, it's an easy job, go to business.
Absolutely. It's definitely not an easy business by any stretch of the imagination, because it's not just a 9-to-5 job. I come in the morning, I've been tossing and turning all night from thinking about the cases, that I'm going in to do surgery tomorrow for. So I'll be thinking about it all night tonight. I've already gone over them. I'll go over it again tonight. Before I wake up in the morning, I'll probably have dreamt about the surgery. Then I'll go in for surgery tomorrow, review it with the patient briefly, and then I'll do my own personal huddle right before going into the operating room and say, okay, these are the steps. These are the dozen parts of the rhinoplasty that I'd like to perform. This part of the procedure, I really have to pay attention for this particular patient to make sure we address this issue that they were having.
So now you went to BU. Where are you originally from?
Originally from northern New Jersey. And then then I went to BU for 8 years, and then I actually went back to Rutgers University for my head and neck surgery training. And then I went north of the border to University of Toronto, which is really a wonderful experience exploring the Canadian medical system, their healthcare system, and as well really getting superb training up north. And then I'm able to bring back those techniques from Canada to the US. The really nice thing about in Canada is that many of the things in the U.S. we're stuck with, our Food and Drug Administration, the FDA, which does a great job in doing their best trying to protect patients. But what it does do is it slows down some of the newer things that come out, some of the newer devices, some of the newer, such as fillers and other
we
things.
We just use other countries as guinea pigs.
Well, we still want to do all of our own training, but the great news is that up there, actually, they used a lot of the European system and a lot of the Canadian system, and so it was a little bit faster.
I mean, I always got a kick out of the fact that the easiest way to get through, a phase 2 or phase 3 trial is to have done it in Europe. I mean, especially the phase 1s. Mm-hmm. Okay, so phase 1, we're only really testing for safety. So we'll use some other country and we'll do the phase 1s there, and if nobody grows a second head or dies prematurely, okay, that's safe enough.
It's a very tough ethical question. All of these drug trials, they take time, and for everyone undergoing it, they're volunteers or paid volunteers, and absolutely it takes a lot of lead work to get any of these things off the ground. And so those companies that go out and invent a new device or try out a new medication, it's just amazing how long it takes from start to finish to get.
I think the hardest course to get my arms around was a course on medical ethics. Because you sit there and say, okay, what is the better solution? Mm-hmm. To expedite phase 1 trials in the US, knowing that you're going to have Americans feeling all these side effects or dying, or to let them happen over there somewhere, so that the only thing we're going to let go to phase 2 is safety, proven products, but then the beginning of our research, you have to wait 7, 8 extra years before you get it in the US. I could argue both sides.
Absolutely. I think this is one of the tough things that we face every day now, and looking at drug prices and trying to figure out all of these items, trying to get patients the medications that they need, but we also really have to go through the safety factor. And so, unfortunately, it's very easy to take advantage of patients who would say maybe desperate for medications, and then they get a medication that probably wasn't right for them to begin with. And so we really do, I think, the due process that's there, I think, maybe a little bit overkill or overmuch, but I think it's really a wonderful
How do you justify $180,000 for a liposome storage disorder drug for one patient? You take that $200,000, you put it into programs in the inner city, you save hundreds.
This is a tough decision. And
it isn't if that patient's my daughter. Mm-hmm. At that point, I'm sorry, I will admit I would become very myopic in my view of life. I want to take care of my son, my daughter, my darling bride, whoever.
Absolutely, and that's my job as a doctor, to also be that advocate for my patients and saying, well, this patient would be great for this medication, this trial, this imaging technique, to take a look. And I know that at the end of the day, we don't have infinite funds. We don't have infinite resources. Thankfully, we do have a lot of resources and a lot of funds in this country to support all of these things, and we're able to provide such stellar care to
Now,
patients.
let me ask you a mean question. The image of a plastic surgeon is Hollywood tweaking somebody's nose or their ears or face lift. How much is reconstructive surgery? Because below the neck, when you think of people going through operations on their breasts, it's not all vanity.
Correct.
I mean, a lot of times it's people who have lost, lumpectomies or whatever, and it's reconstructive. Mm-hmm. In your practice, when you think of facial operations, how much is, I guess, reconstruction or necessary versus somebody like me that says, okay, I'm an ugly old man, make me look young again?
Well, I'd say, first of all, that a lot of the surgery that I do is functional and or reconstructive. So, for example, I do a lot of rhinoplasty for patients, and it's really because they're not breathing well out of their nose. The nose job aspect of it, to look nicer, well, that's a side point for many of my patients. Most importantly, when they come in, they want to breathe better. And so it may be opening up the internal parts of the nose. And my training as a head and neck surgeon actually keys in on both. So I'm trained in both the functional aspects of the nose, the breathing standpoint, making sure there's good structure in the nose, and then also the cosmetic standpoint, meaning making it look good.
Well,
and so those
is it true that you got to smush my nose?
Well, those two things come part and parcel.
I mean, I see, again, on TV, they're taking a hammer to this poor kid's nose.
For many patients, it is actually straightening the bones. There different parts of the nose actually need
bend it a little.
Different parts of the nose need different tweaks and different things. And so for a lot of it, it's adjusting cartilage. And so the squishy part of the nose, the very end of the nose, that's all good cartilage underneath the skin. And unfortunately, though, for many patients, whether it's trauma or just their genetics, well, yeah, their nose, the actual bony part, the stiff part up top, is crooked. And so that may be impinging on their breathing. That may not be looking that good. And so to straighten
But now,
bones,
from the functional point of view, not breathing well, I mean, you hear, well, then you snore. Okay, that's annoying. But you can have some real negative effects if you're not breathing well, right?
Absolutely. Absolutely. There are many patients that I see who can't exercise because when they're breathing in deeply, their nose puckers in. And so absolutely they can't sniff without their nose collapsing.
Puckers in?
They'll see actually you'll see some people whose nostrils will flare, and some people, instead of their nostrils flaring out, will actually start to flare in. And that's because just like when you sip a straw, sometimes the walls of the straw collapse, and sometimes that can happen in the nose as well. So of course then what you need is a stronger straw. And my job as a facial plastic surgeon is to take some good cartilage, some good strength, and in addition to the cosmetic standpoint, but build in good structure. And so there we really strengthen the nose. So at the end of the day, the nose is actually stronger than when it started.
Where do you get good cartilage?
So from actually inside the nose itself, we have that septum, which you always hear about, deviated septum or crooked septum. Well, that septal cartilage, actually, some of it we need is really good strength to hold up our nose. And then actually further back, that cartilage can be used, sculpted very carefully on the operating room table, and then carefully placed into the nose itself.
Now, when you say sculpted, you're actually like shaving it?
I'm taking a very small knife, a little scalpel, and we're trimming off individual pieces. And so it's literally, I'm measuring out by the millimeters, this piece, and lining up the two pieces together, making sure they're exactly the same.
And then crazy gluing them in place?
Well, then we have to make little pockets into every place and using really fine sutures. So the sutures that I'm using, for some of them are much thicker than a human hair. Some of them end up being about the same thickness.
Well, I remember
as a
when they
human
did
hair.
my cataracts. And of course, being a man, did I listen to my surgeon? Of course not. And I overtaxed the eye, and it bled. So he told me he had to go in and fix it and suture my eye. The idea, because he said he made a 3-millimeter cut to get the new lens in. But I'm trying to think, how can you suture a 3-millimeter cut?
Very carefully. That's the key, very carefully, and under magnification. So we do have a helping hand with some magnification for many particular surgeries.
Up here, how do you, when you say magnification, how?
I've actually got some fancy glasses that give me about 2.5 to 3 times magnification. And so there I'm able to really
But you can
delve
see
into
up the nasal cavity?
Absolutely. I have a headlight on, and so that is able to project some good light for me, and it works directly into my magnified field.
So now, from a functional point of view, how do I know that I've got a breathing problem? Is that something my GP figures out, or?
It's something actually that you would figure out. Very much, when a patient comes to me and says, oh, the doctor told me that I had a deviated nasal septum. I tell everyone 70% of people have a deviated septum. It doesn't mean 70% of people need surgery. What really, when someone comes in, it doesn't matter almost what I see. It's when they come in and say, I just can't breathe through one side of the nose, or my nose does,
So
I'm
when
snoring.
you do deviated septum, it's not an all or it's not a 90-degree turn or nothing.
Sometimes it is, and
But-
the deviated septums that go 90 degrees are much more difficult than the gentle curves. And sometimes it's just a matter of, a little trauma when we were 8 years old, or sometimes it was maybe even, I tell patients, it's because you turned right in your mom's womb instead of left, and that maybe just pushed the septum over and made it
My
grow a
mother
little bit
did this to
differently.
me? No. My sainted mother would never hurt me.
Well, that's why we breathe so well through the nose.
So realistically, you could, when they say you have a deviated septum, it could be a couple degrees off, it could be.
Absolutely, and sometimes there's even a big spur. It comes off and does a big zigzag, and that's okay. If you're breathing well, no nosebleeds, you're able to exercise, you're not snoring, then you don't have obstructive sleep apnea, then absolutely let it be.
So now, snoring. Yes, my darling bride has threatened to put a pillow over my face many a night. That could be just deviated septum or just bad breathing?
Absolutely, absolutely. There are many different structures inside the nose. The septum, the turbinates, which are shelves inside the nose that help spin the air, clean the air for us as we breathe. Sometimes they're too large. And so as my job is to take a look in and say from the tip
So
of the
you could be
nose all the
filling
way to the
pockets.
back. Absolutely, it's to take a look and see what needs to be shrunk or moved or adjusted into place to get your breathing the best it can.
So far it sounds like you haven't used a hammer.
Well, to move the bones over, unfortunately, that does sometimes take a hammer, because we do have to break the bones to move them over.
Eesh. So you break my nose.
Mm-hmm.
Now obviously you've had to practice, hopefully on cadaveric
Absolutely.
models.
During training, we have all sorts of cadaveric labs, and then we've had various traumas to the nose. So I used to work at a big trauma center, and so we'd see patients who unfortunately were, had got into fights or motor vehicle accidents, or other even horrendous tumors that have invaded different structures. And so therefore, you really try to do your best to recreate normal structures.
I hadn't even thought about that. So you may have to work with oncologists.
Absolutely. Actually, a good part of my practice is working with various head and neck cancers. I do a lot of skin cancer treatment in the office. Actually, I had a patient just yesterday in the office who we were working on his skin cancer, which has been an ongoing issue for him. And so absolutely, we can take off those little skin cancers, send them to the lab, see if they're just benign nothings, or if there's something that we need to get more excited about. And the good news then, if we need to take it off in the office or move around other areas, other skin areas of the face, then we can do that and recreate those good normal structures.
So now, if I develop skin cancer, is it a little conifer, a little scalpel that you're zipping it off, or are you freezing it, or?
So it depends actually a lot on training. So dermatologists do a lot more freezing. Obviously, it depends on what it looks like. If we're thinking that it's pigmented, meaning kind of dark, well then we always think maybe this is a melanoma. And so absolutely then we need to do a biopsy. The most common forms of skin cancer, basal cell carcinoma, which more than 40% of the population will see in themselves at some point in their life, versus squamous cell carcinoma. And then melanoma is kind of way down on the list, thankfully. And so
Luckily.
A lot of those, exactly. So a lot of those basal cells and squamous cells, actually we can freeze off or shave, or what we call curetting off. And absolutely then we don't have to worry about as big reconstructions. Although unfortunately, sometimes people let them go for a little while, or they do grow rapidly. And then we have to get more exciting with an actual excision. Obviously, if it's melanoma, then you have to get a big excision and also some imaging if it were melanoma. But most of the other skin cancers we can take care of.
So if
very
it's
simply.
a melanoma, you're going to dig deep, right, to get outside the envelope, or?
Absolutely. So each and every type of skin cancer, we have to go to a different range around it. So basal cell, actually, it's not very aggressive. And so we can really do very close margins around it. Squamous cell tends to be a little bit more aggressive, and melanoma, much more aggressive. And so then we have to do different lengths of what we call margins, or basically the area around it we have to cut out at different rates to know that we get a surgical cure. And that's really our goal, is
So
that
now,
cure.
you hear if it's round and happy looking, it could just be a mole. But if it gets black or funny, you know, it's not circular, go to your GP.
Absolutely.
Then the GP looks at it and says, I don't like it. They send it to a dermatologist, or they send them to you, or how does that work?
Generally, a lot of them will end up going to the dermatologist first. Because dermatologists, first and foremost, they're trained in all sorts of skin disorders. And so I'll often get referrals from the dermatologist then, once they've done a biopsy, and they said, okay, well, we need to go to the next course in therapy. There are many patients who just walk in my door, and they come in with various other issues, and I say, have you taken a look at this area? And sure enough, it's usually the significant other who gives an elbow, and they say, you know, it's been there for a year, and it keeps bleeding, or you keep scratching it. And then I say, you know what, it's probably time to do a little biopsy. And so we'll go ahead and do that.
So I go to a dermatologist. That's an MD.
Yes.
I mean, that's a real doctor.
Yep, and they've gone through their formal training and board certification as well.
And they punch a little hole and do a biopsy and see if the little bandit grows. Now, if it does, do they normally handle it, or do they hand it off to you?
That's a great question. So they may be able to handle it all on their own. There are specific dermatologists that have undergone a specialized training called Mohs surgery, where they'll actually take out the tumor and then look at the individual margins under the microscope right there and then. And it's actually a very cost-effective way for especially the more aggressive tumors, or the tumors that are really in tight areas. So we talked about the eyelid, right? You don't want to take out more skin around the eyelid than you need to, or even on parts of the nose.
A myeloma in the eyelid?
Unfortunately, the skin cancers, when we're out in the sun and not wearing sunscreen, our whole face is getting exposed to that UV radiation. And so unfortunately, I do see some skin cancers of the eyelid. Now, the Mohs surgeon will cut it out, and many Mohs surgeons actually will close up that area and fix the hole that they made. And sometimes they call in facial plastic surgeons like myself and say, you know, I think this patient would really benefit from your expertise.
Yeah, I like an eyelid. I don't want you cutting out a chunk of it so that I can't close my eyes anymore.
Absolutely, and then it's my job as the reconstructive surgeon to then say, okay, let's move some tissue from this area to this area. And that's actually a very creative and interesting role that I get to play. It really goes on to my creativity, but also I really do some great good for my patients and making them restore their appearance.
But you're not moving like stem cells that haven't decided what they're going to be when they grow up.
No, often it's tissue that's right next door. And so it's sliding things over, or maybe it's from the other side or a different part. Sometimes we do skin grafts, let's say from behind the ear, where the scar may not be noticeable, or even right in front of the ear, where we can do a little.
I just don't want to hear that, you know, you hear that they've taken fat out of your bum and put it, it's like, no.
Well, that wouldn't be for reconstructive purposes.
No, that would
be more
cosmetic.
For cosmetic purposes.
And I'm sitting there saying, okay, wait a minute, you're going to put bum fat in your face. I'm not kissing your bum every time I come over, Grandma. I'm sorry, there's got to be a limit here. But the skin cancer that you get involved in, mainly due to exposure in the sun, not using good sunscreen?
I'd say number one, absolutely. You know, it's definitely, you know, UV exposure is the number one thing that we all see, and unfortunately, the more years of not wearing sunscreen, the worse it is. We still see it in young people, especially, you know, then in Australia and New Zealand, where the ozone layer is a little thinner. They see just astronomical rates, but we still see it in North America, and even still up in Boston, even though the weather's not always that nice.
You got Portuguese like me that, you know, I mean, dark meat. You know, my mother became a Hershey Kiss in the summer, as my youngest does. My father, I mean, it was all genetics. He couldn't have his arm out the car door while he was driving, out the window, because he would burn. But how much effect do genetics have? I mean, how much melanin do you need before you're safe?
Well, it's huge actually. The range we see is quite dramatic. So we know in Caucasians, especially from the from the UK area, at least in terms of descent, being from the
Redhead Irish.
Area, Redhead Irish, we know that their rates of skin cancer are just much higher, and we know that the African populations, their rates of skin cancer are much lower. Notice I didn't say zero though. So even still, when I see very dark-skinned patients, I tell them the answer is you still should be wearing sunscreen. I often get laughed out as they walk out of the office, but I still tell them that it's really important because we still see some skin cancers happen in that population. And so I tell them, absolutely, you have to. I tell everybody, from when it doesn't matter what age you are to whatever age you might be at some point in your life, the answer is skin cancer is a possibility. It does run in families, we know. We know that once you have one, you're at much higher risk of getting another one. And so very much prevention is the key.
Now, when you say once you've had a spot of skin cancer, you're much higher risk of getting a second. Why?
Well, that's because that one particular area got enough sun exposure that those DNA were damaged to form a skin cancer. Well, guess what? Right next door, it's not like that skin got less sun exposure.
Okay, so it's not.
It got basically the same.
It didn't spread. It's not
No.
like it sent antigens through the body and.
No.
It's just.
Although skin cancers can unfortunately spread through the body, but overall, it's absolutely. If you're laying out and your whole chest, face, neck,
so it's
we're
just
all
the
exposed.
odds are that your whole chest or your whole back got zorched.
Absolutely, and so if one area has a skin cancer, right next door could just as easily pop up. It may not be now, may not be in a year or 2 years, or 10 years, but at some point it might be an issue. And so,
how do I know?
I think absolutely the number one way is to have a doctor take a look at it, and also for you to take a look at it yourself. If patients say, you know what, I've seen this spot, I've noticed over the past 3 months, it went from being this big to this big. I noticed that it went from smooth to rough. These are all things where I say, well, you're really taking a keen eye, you're really being careful about your health. And so absolutely, you think this is an issue, I'm very strongly
But that
think
works
this is an issue.
the front of me. And some of us rotundness, there's a lot of area there. But I need help to really, when you think about your significant other, whether it's man, woman, whatever, they need to be looking at your back and your backside and everything else.
Absolutely, and that's where I call on my dermatology colleagues, because as a facial plastic surgeon, I always joke with my patients that the clothes get to stay on. Or versus when you go to the dermatologist, they'll really want to do a full body, what they call a full body scan. And so they'll actually have you, go down to your skin.
Yeah, and I told him if he laughs, I'm kicking him.
That's it, but their job is really to look at the whole body. And therefore, they'll be able to pick up on some of these things. And my job as well when I see patients in the office is to take a look and say, you know what, this area just doesn't look right. Let's do a little biopsy here.
So now, most of the cases you work on, is it nose, is it face?
It's actually quite a mixture. So I do a fair bit of rhinoplasty and helping patients breathe better. I also do a fair bit of facial rejuvenation surgery. And so facial rejuvenation surgery can go from the non-surgical aspects, the things like Botox and fillers, but also go to the things like facelift, eyelid lift, brow lift, where we really get to do pretty extensive work in rejuvenating the face and regenerating some of those little
Botox.
structures.
Botulitum. Wait a minute. I'm going to take a toxin and voluntarily inject it into my face? What's that about?
It's actually one of the most studied medications in the history of mankind. So first of all, whenever we think about things, I always tell patients this to give them that sense of security, because absolutely, Botox is actually being used for more things today than almost any other medication ever, and it's still being studied for more indications. So originally we saw that it worked for some spasm of the eyelid, and so that was actually some Vancouver ophthalmologists actually noticed this. And then they actually injected it into other places. And so we know that it works to soften the muscle effect for various areas. So it works on the eyes. It can work on some forehead wrinkles as well. It can work on those crow's feet. But we also have really expanded those indications. So actually our neurology colleagues have found that it works great for migraines. We've also seen that it works great for chronic pain. We've also seen that it works great for children with cerebral palsy or spasticity issues. They can actually get very, very high doses of Botox. I kind of laugh because I think if I do, a fair bit of Botox on one patient, and I know that those neurologists working on a small child with spasticity issue, they'll use 3 or 4 times the amount of Botox and not even bat an eye at it because they'll be doing much stronger muscles.
So now I get wrinkles. That I'm getting older, the muscles are tightening.
What happens is that those, first of all, 3 things really happen as we age. First, we all lose a little bit of volume, right? And we all
I
know
gained
that
volume. I gained lots of volume.
But we even lose some good volume in our skin. We lose it actually in our bones. Our bones start to shrink.
Okay.
Our skin, our fat, our muscle, they all actually start to shrink, even though some places we do add a little bit of fat. The next thing is that things start to sag. And so unfortunately we see this, and many male and female patients will notice different things sagging at maybe different times, or maybe they won't admit to things sagging all over their body, but we see it in the face. And then the third thing is sun exposure. And so all of those things together can lead to wrinkle formation. And so absolutely up here, we often see it for patients with, that kind of worried look or angry look on their face.
Well, you've seen leather skin,
Absolutely.
alligator people who have lived on the beach and their skin looks like alligator leather.
Yeah, and some of that is lots of sun exposure. For many patients, it's a combination of maybe some sun exposure, maybe just a very active or expressive forehead. I have one staff member with quite an expressive forehead, and so Botox is really a good answer to soften the effect.
But when you say soften, what is it actually doing?
So what it's doing is it's actually telling the nerve, and it's preventing the nerve from communicating to the muscle as much. So it's almost like a little bit of paralysis. But we don't put enough, oftentimes, to paralyze the muscle, but we just weaken the signal. So we just tell it to send fewer signals to that muscle.
I'm a nerve, I'm saying tighten.
Yeah.
And when you do this, it just kind of lets it smooth out?
Exactly. So now instead of it, you say, oh, let's give 100% contraction, maybe it only says, let's do 20%. And so for a lot of patients, they still have an expressive forehead, but it's just a little bit softer. It's a little bit gentler. And so when they look in the mirror, they say, you know what, I just look happier. The funniest was I actually had, in the course of a week, I had a judge and a lawyer who came in to talk about Botox. And the judge said, let's do the Botox, but I can't go too heavy on the Botox because when I see lawyers in my courtroom, I need to scowl at them. I need them to know when I'm angry. And it was just a few days later, I saw a lawyer who, not the same type of law, but a lawyer who came in and said, when I talk to judges after I get my Botox, they don't see me quite as so angry. And they actually tend to go more in my favor, I've noticed. So absolutely, I actually had to go lighter on the judge and a little bit heavier on the lawyer.
But now, physiologically, the body tends to not be happy when you mess with it. So you Botox me on January 1st. Immediately the body starts saying, okay, let's fix this.
Absolutely. And so Botox itself just sets the clock back. And so you continue to age. And actually over the course of about 3 or 4 months, that nerve muscle connection will recover 100%.
Okay.
So I tell people that, even if you didn't like the effect, but if you have it January 1, when you're looking
by
at
April, I'm back to where I was.
You're back to where you were. And so the nice thing about Botox is we get to repeat it if you like it. We can adjust it if you didn't like it. We can not do it. And so actually now we know, Botox we know lasts about 3 to 4 months. We can do higher strengths, which tend to last longer. But I always tell patients, at least when they start with me, let's get it right, and then let's see if, maybe doing a longer term therapy is better for you.
Foreheads, eyes, where else do you Botox?
Sometimes for the upper lip, because some patients will get those smoker lines, what we call kind of grid lines or something like that they really don't like. Oftentimes actually the corners of the mouth can start to droop. And so doing a little bit of Botox there can lift the corners of the mouth. Some people really get very thick cheek muscles, those masseter
like
muscles.
jowls?
Like jowls. But actually kind of a little bit higher up, and they'll say it's just heavy looking. Or they clench their jaws. And so then we can put some Botox in there to soften it.
Is this stuff expensive?
So it's not, unfortunately, it's
Well, it's voluntary, so you're
it-
not going to get covered by a lot of insurances.
correct. And actually for what we do for patients with migraines is we actually go through the insurance process to get it all paid for. on the cosmetic standpoint, though, it is something that's elective. And so I tell people, you can do it as often as you like, well, every 3 to 4 months, or even not as often.
But is this thousands of dollars per?
No, and generally, the good thing is I've had some patients who come to me just once a year, and they say, you know what, I just got that, Christmas bonus, let's do something.
So it's in the hundreds.
Let's do something nice, absolutely.
So it's not like, the rich of Hollywood can afford it, and then nobody else.
No, and Botox itself, it's much more accessible today than it was before. The prices have really come down because more and more people are doing it. Although, I always tell patients to make sure to go, especially to someone who knows what they're doing, knows the anatomy, because unfortunately there are other people who are out there who may have gone to a weekend course and don't really know the anatomy that well.
So then my whole face...
Unfortunately, it's not as well regulated as some of us would like.
You hear and you see some of these celebrities. I mean, I am an old man. I know I look like an old man. I am proud to be an old man. But you see some of these people where their faces looks like they've been stretched beyond stretch.
And those are the patients that really give Botox, fillers, facial plastic surgery a bad name. And then you look at those other people who are in the magazines, maybe right next door, and you say, well, they just look nice. And when I see a patient in the office, that's my goal. Is I always tell patients, my goal is just for you to say, you know what, I'm just looking nice. I just look refreshed.
Well, I remember Joan Rivers when she was saying, I think I'm smiling. Am I smiling? Because it seemed like her face was stretched beyond stretch.
Absolutely, and I think a lot of our techniques have come a long way, and so it used to be that facelift was really a skin lift procedure, and I think unfortunately
you
many
saw where they pulled
in the past,
back. I mean, they showed on some of these Discovery Channel that they were taking the skin off the face and pulling it back.
And actually what I do for a facelift is I actually go underneath the skin and tighten all the good structures underneath. And then actually I don't tighten the skin. I just lay the skin back down and see what skin is extra. What skin is excess, well, that I trim. And so that's
You're trimming my face?
Procedure. Absolutely, it's that extra skin that's just been a little bit of lax. And so really it's amazing when patients come in after a facelift, they've had this extra skin that's been hanging around and they just say, yeah, I just look refreshed. Actually, a lot of patients would come in and they say, people like my eyes. And the answer was, you had a facelift. Nothing happened to your eyes.
I can see them now. The skin isn't hanging.
Yeah. Well, people will come up and they say, something's different, something's nice about you. I've had rhinoplasty patients who, people comment about their eyes, or facelift patients, and they'll put on a new shade of lipstick, and everyone just talks about their lipstick and how nice they look. And the answer is, well, yeah, it's a nice shade of lipstick, but they also had a wonderful face and neck lift. And their jaw neckline's looking fantastic, and that's really wonderful.
A neck lift?
Absolutely.
Okay, I got to ask, what is a neck lift?
So as for many patients, not just the face starts to droop, but some people will have that kind of gobble neck, that turkey neck that they really don't like. And even still, some people will just get a little bit of fat. And so that neck lift, what we do is we come underneath the skin of the face, and as well under the neck, we lift up those structures.
You make it sound so easy. You're pulling on my body.
The nice thing is it's actually a very elegant procedure. It's actually the procedure that I love to do the most is lifting up those structures, because I know right there on the table I get to see that lift. I get to see that jaw neckline, which went from being a little bit of this to being really nice contour. And yeah, we always lose a little bit, and that's okay. We really have gotten that really nice improvement, which I love to see.
And you stop at the shoulders?
I do. There are other surgeons who I'm very happy when patients come in and say, oh, can you do any breast work? And I say, no, but I'm happy to find you someone who can.
I wasn't even thinking of breasts, I was thinking of bellies.
The same thing. Absolutely. There are a lot of patients who would benefit from an abdominoplasty, a tummy tuck. I don't do that. Again, all of my training, I'm specifically trained in just here. So therefore, I think of myself as the expert when it comes to facial plastic
And there's enough
procedures.
people to keep you busy?
Between all the skin cancers, cosmetic procedures, reconstructive procedures, functional procedures, there's quite a bit.
What other things do you pull on and tug?
Well, specifically the eyelids, the upper eyelids, we can trim off some extra skin. And so for some people, they'll notice their eyelids just look heavy or saggy, or they look tired. And they go, I'm wide awake, but everyone thinks I'm sad or angry or tired. And I say, well, maybe upper eyelid or lower eyelid procedure is right for you. As well, there are many people who start to have their, their brows start to hang down.
But wait a minute, my eyelids, have they stretched?
They have. We blink about 10,000 times a day. Think about that. That's a lot of stretch on that skin. And so, yeah, we do get some extra skin that's there. And so we do a nice,
I still can close my eyes.
Procedure. Absolutely.
I was going to say, when you're trimming away.
Absolutely. The number one thing is just to get that nice refreshed look. I always tell patients that if ever I'm faced with the decision of taking a millimeter more or leaving the millimeter, I'm always going to leave it. Because I always want to make sure, number one, we have to function. And if we have a little bit of excess eyelid skin, that's okay. But the goal is those patients who just find that it's heavy. Well, yeah, I can trim off just a touch, and therefore they can just look a little bit more awake, refreshed, rejuvenated. They're ready to go. It's really wonderful when patients, come in from the boardroom and they say, you know what, people are looking at me and they're seeing my age. And actually, eyelids tend to be one of the first things that people will notice as they age. And so they'll come in and we'll do usually an upper blepharoplasty. The nice thing is we can even do that in the office, in our procedure room, which is just wonderful. Other procedures, they're more advanced, and therefore we need some anesthesia on board, and so we do that in the operating room.
What do you mean you need some anesthesia? You do some of these things without anesthesia?
Well, we do it all with local anesthesia.
Well, I understand, but
general anesthesia. Absolutely. It's amazing, actually.
You're cutting parts of my eyelid and I'm awake?
Absolutely. We do it all with some local anesthesia, and the patients are very comfortable. The first thing with the little needle for the injection, well, that's not that much fun. But after that, the area is really numb.
When they did my dental procedures, I put myself to sleep so I don't have to watch it and deal with it.
Absolutely. I've had many patients who snooze on me, even with the upper eyelids.
That would be better than to watch, people ask, do you have any allergies? Yes. Sticking sharp objects in my old body.
Well, the good news is even still when we're working on the eyelids, you have to keep your eyes closed.
Oh, thank God. Now, the only part of my head so far that's saying, yay, he hasn't talked about me, are ears. Mm-hmm. Do you do anything with the ears?
I do. So there are many patients who come in with ears that stick out. Unfortunately, especially we see it in little kids where their ears stick out and they get made fun of on the playground. We see many political ads in the past few years as well with some of our politicians in the news on both parties who have had some prominent ears, and unfortunately they get made fun of even on the national stage. And so it's really quite sad, I think.
They get made fun of because of their ears?
Oh, absolutely.
Holy moly, Batman.
And so for many patients, actually, it's that what we call pinning the ears. We actually can do that both with many different techniques. Some are open, meaning with surgery, but actually I was trained in what we call an incisionless technique, where we just use some sutures in very carefully placed areas. And so there's no external cuts, just sutures to help bring those ears back to a nicer position.
So you don't reduce the size?
Sometimes we do, for some people with very large ears, but most often I find actually if we're able to bring the ears back to a more natural location, that even larger ears will be overlooked then.
So if you're pinning them back, you're not necessarily putting a pin in them.
Correct. No, just maybe some sutures, and as well as some other sculpting techniques that we'll do to really just adjust the ears to a more natural
Seems
look.
like more and more everything's going to some kind of crazy glue. I mean, I was amazed because I just went through open heart surgery and there were no sutures. I got 7 rings of steel holding my chest together, but when I looked down, it was all glue.
That's fantastic.
It just amazed me, and you're talking about gluing parts back into my nose, and yeah. I'm glad that you can do it.
It's really amazing what the human body can do, and it's amazing the power of healing that all of our bodies can do. And so that's really what we rely on, is the human body to take over. And my job is just to put things in nicer locations and adjust things, tighten different areas,
But
and
now,
then allow the healing
when you
to
talk
happen.
about a rhinoplasty, we've dealt with the functional. I mean, there's got to be people that come to you for cosmetic procedures.
Absolutely.
What are the most common?
In terms of cosmetic procedures, really the eyelids, facelift, rhinoplasty is one as well.
But when you do rhinoplasty, is it shrinking it? Is it pointing it? I mean, what do you...
It depends actually by ethnicity. So many patients will come in, and we see many patients with large noses. They say, oh yeah, I've got daddy's nose. And so daddy's nose may be a little bit larger. It may not look as good in that smaller person. And so then we're reducing structures. For other patients, it's actually adding what we call augmentation rhinoplasty. We're actually adding structure, we're adding volume.
Somebody wants a bigger nose?
We do see it in patients of various ethnicities. So we see it more common in Asian patients, that they'll want a larger profile of the nose, because many of them can have a slight flatter appearance of the bridge of their nose, versus many of the Caucasian patients, especially of various ethnicities and various descents, will come in with that hump of the nose or some bigger deviation. They say, I just want to be a little bit smaller.
So I got a big schnoz. Is it the cartilage that's big? Is it the skin? What makes my nose big?
It's usually a combination. So it's both the skin, which you may have thicker skin because you're Portuguese a background, and so absolutely you have thicker skin, but also it's those bones, it's those cartilages underneath, which can all be trimmed, structured, adjusted to be in better anatomical places.
So you're going to cut my skin away and sand it down?
Actually, for a rhinoplasty, we make a small incision just underneath the nose. And I always tell patients, I lift up the skin of the nose just like lifting up the hood of a car. Then I take a look at the guts of the engine. And so just with a little incision under here that's carried out on the inside, then I'm able to take a look at that good structure of the tip of the nose, a little bit higher up, and then those bones themselves.
And then you can sand down the bones, or?
Absolutely. We can sand down the bones. We can carefully shave and sculpt the cartilage. We can move those bones that we talked about earlier with breaking. It's quite amazing then what we're able to adjust for noses and adjust profiles.
Now, you know, probably the bane of your existence are these shows like Botched that show woman or man with 4 nose jobs and there's no cartilage left. Now what do you do? How real are those type shows?
So I'd say, unfortunately, there are some patients who've had several rhinoplasties that just didn't work. And unfortunately, what can often happen is that one surgery may not have come out quite as well as they had hoped. They went in for a second surgery, and then things started going downhill. The third surgery went even more. And
well, I mean, if you keep shaving.
Well, and some will add and subtract in different areas. Then we're dealing with all the scar tissue. And so then, unfortunately, we're stuck with putting in more structure. Then we talk about actually taking structure from the ear, from the cartilage itself, or even from the rib, a piece of the cartilage there. And that's really good, strong cartilage. And then we can reconstruct all the guts, those engine parts inside the nose. But it's definitely not an easy procedure when we're down that road, down those many rhinoplasties.
So you really then, I mean, you're going up against the wall saying, okay, this is too thin to begin with. Now I got to build it up so then I can shape it.
Absolutely. And I always tell those patients, the goal is better. We're never going to get, especially when we talk about third, fourth time revisions, we're never going to get the nose to be spectacular.
So they come in with a picture of an actor or an actress and say, give me her nose or his nose?
And sometimes patients do. And I say, that's just not going to happen. Because the goal is actually just to have a nice, natural appearing nose. Actually, when we walk down the street, you never say, oh yeah, they've got a nice looking nose. You know, you say, oh, that person has nice eyes, they've got a nice smile, they've got nice hair, but you never say they've got a nice nose. And that's because what we know is that the nose being where it is, as long as it fits in with the face, as long as it's a natural appearing nose, then our eyes don't go to it. So absolutely, it comes back to those patients who come in after surgery, and people say, they think my eyes look great, but I just had a nose job. And I say, that's perfect success. That's what we shoot for, is a nice, natural looking nose. And then it just blends in, and that's just who you are then. That's just that inner perception of who you are that wasn't reflected on the outside. And so then my job is to help make the outside reflect that inner spirit that you have.
Do you have to tell some people no?
I do. And that's actually one of the toughest things that we talk about in the office, and that I talk with my staff a lot about, is making sure that each and every patient knows what we can do and what we can't do. And I always try to undersell what I do with patients. I always say, you know what, our goal is better. If we get that dorsal hump, that bump in the nose to be just right, well, that's great. But better, meaning even just a slight bump, well, that's okay, that's natural. That's the way that we all fit in, that's the human condition. And so that's really the goal. If we get that perfect 10, hey, that's fantastic. But my goal is always that nice natural look. And then that to me is really success.
So you can get people that want the pointy, perfect nose, and you sit there and say, genetics is working against you.
Absolutely. If you want, for example, for you, you have that thicker skin. If you wanted a petite little nose, I'd say, Al, this isn't going to happen. You got to go back from when you started, back from when you were, one cell large, to be able to change some of those things. Because, yeah, that boat has left. But what we can do is get you that nice natural-looking nose. And so I have some patients who say, you know what, I'm not the right person for them. And I tell them that's okay. My job is not to do every patient who walks in the door asking for a rhinoplasty or asking for a facelift. But my job really is to get those patients that meet my expectations, that I can meet their expectations, and I know that we can have a great relationship with.
Well, that's got to be a reflection on you. I mean, if you put out a funny looking nose and I say, who did it? Well, he did. Well, okay, I don't think I really want to go to him anymore.
Absolutely, and that comes back to actually the discussion we were having before, is that there are many patients who go in for surgeries that I just wouldn't believe would benefit from them. And I don't believe that it would be a calling card for me that I would want to say yes, to the world. This is the procedure that I did for this patient, and I don't think they look great, but they love this extreme look. And I'd say absolutely. If you want that extreme look, that's
go
you
somewhere
can
else.
go somewhere else. My job is that natural
Because you
look.
see these people who want to look like Barbie dolls, and they've had ribs removed. I mean, I can't imagine why a physician would do that.
It's very tough. Sometimes in talking with patients, when I talk to a patient about especially cosmetic procedures, I want to make sure that that's what they want. And for many patients, it is what they want. And then it's a reflection back to me and say, is that what I want for my patient? Do I really think that even though that's what they say they want, is that what they truly have in their best interests? And sometimes it's my job to say no.
Yeah,
It's
it can't
really
be
hard
good
to say
for
no.
you. I mean, we were designed with a certain number of ribs. There's a reason. What you said, nipping a little cartilage here or there, it'll come back. Yeah.
Well, it won't come back, but at least
No,
we're
but
leaving the
the
good
look,
structure there.
the look will
absolutely.
come back.
Mm-hmm.
You're putting a little incision, okay, no big deal.
Right.
Removing a rib, there's nothing to come back.
No, and I think we do. Each and every one of us battles those ethical decisions in our lives and our jobs, and we say, well, what makes sense for me? I know for myself, I'm a surgeon. I have certain limitations of things that I can do, things that I do well, things that I don't do well. Things that I don't do well, I want to make sure that I get those patients who come in wanting that to the right expert. For other patients, I say, well, this is what I do. This falls right into my wheelhouse. Yeah, let's talk about that procedure.
Well, it also has to give your peers, you think if I'm an oncologist and I know that you're going to put what's best for my patient first, versus, well, I also want this and I also want, well, I mean, that's, like you said, that ship sailed. Your genetic profile just isn't going to let me do that.
Absolutely, and it even comes to some of my cancer patients who they say, well, I just want this to look right again. I just want to look like myself again. And unfortunately for many of them who have had these bad tumors that have eroded different areas, the goal is to make them look good again, not necessarily
Perfect.
perfect. And so we always try to do as much as we can, but we know there are still limitations on what we have.
Is the technology evolving for you?
Absolutely. I think from now, Botox only came out in the late 80s, really. Fillers have come a long way. And so there are many ways, and there are many other devices that are on the market now. Many of them, the science isn't that great, but many of them actually, I think, are devices that have waited to find the right way that they're good. And so for many patients, for example, for scars, there used to be kind of set ways to do it. We used to use various machines to help with scars or revise the scars. But now I actually treat many scars with filler therapy. So the same fillers I do to give someone nice lips or nice high cheekbones, actually that depressed scar can really look nice and flat, and therefore the eye doesn't catch it. So for example, I've had many head and neck cancer patients who have had big scars here because their lip was split for surgery, or they had bigger reconstructions. And yeah, there I can make that scar look nicer, flatter, smoother, and therefore when they go about their daily life, people don't say, oh, they obviously had a big surgery. No, they maybe had like a little, a little wrinkle that's there. Hey, if I can make a deep scar look like a wrinkle, that's a win. If I can do something where, maybe it's not 100%, but again, 80% better.
I mean, I'm thinking friends older who had open heart surgery. Their scar makes me feel embarrassed. Because mine now, we're a month and so past surgery, and it's almost going away. I mean, it's there, but it's really, really light. You don't see the railroad tracks.
Right, and unfortunately, some scars are there, and we do our best to get them better. Some scars, even though better, may not be great. And so I tell all patients who come in for scar management, if we can make this a little bit better, that's great. Some patients we know are just formed keloids, those very active scars that can grow outside of where they started. Well, those patients, we can restart the process, and hopefully they stay away, and we try to fight those.
How does somebody get a hold of you?
So the best way to get a hold of me is to show up in my office, first of all.
Where is that?
So my office is at 308 Main Street. It's the Milford Ear, Nose, and Throat Surgery office. And so you can find me through the Milford.
Is that where the cardiology, Dr. Shine, is on the other side?
Dr. Shine and I split an office. It's a wonderful group.
Because I was just there.
Well, that's great. You could have come on down to see me if you wanted to.
Yeah.
But absolutely, you can go there on the Milford Regional Physician Group website. I actually put a personal website together. This way I can help patients even more with some of the good information. So hopefully I'll be able to include that with you.
Well, I hope you'll stay around Milford for a long time.
Sounds great.
And again, it's always amazing the type of surgeons, the type of physicians, and the services you can get right here at the center of the universe. I found this amazing because, cosmetic surgery to me is what I see on TV, and that's less than what I'd want to go through. But I would feel very comfortable if you recommended something going through that procedure. So thank you to our 6 loyal viewers. May God bless. May tonight be a better night than tomorrow. Good night, all.
Not too long since I've been home.